All right. Well, thanks to Dr. Coates. And we will have the question session at the end of the pod. So to keep us going, we're really pleased. Our next speaker is going to be talking about a hot topic. We already kind of mentioned it this morning about the JAK inhibitors. And Dr. Eric Ruderman is going to talk about JAK inhibitors in psoriasis and psoriatic arthritis. Eric, welcome.
Thank you, Artie, and thank you, Jack, for inviting me to come here. It's such a pleasure. So what I'm going to try to do today is talk a little bit about some background and a little about sort of the landscape of what we're thinking about in terms of JAK inhibitors and psoriatic disease. I'm not going to dump a ton of data on you. I actually sent out in my pre-read stuff a lot of the data slides you're going to see, as well as some additional ones. So if you really want to see that, it's there, along with a review paper that I think can be helpful. But I wanted to kind of give you enough of the data, and my questions are some cases. And they're actually people, not entirely, I've edited a little bit to protect identities, but they're people I've seen. And there are no right answers to the questions I'm going to give you, because it's really meant to get a sense of what people think and how people are using some of these drugs in psoriatic disease. And so with that, let's take off. Here are my disclosures. They're in the handout as well. So, I mean, the first question is, why is this even a topic? And the truth is, we've been chasing oral small molecules for 25, 30 years. Even before there were biologics, there was a lot of interest in this, and the idea was an oral drug is certainly preferable for many people, not everybody, but for many people, to injecting yourself with something, or certainly IV therapy. There are many cytokine pathways that are involved in psoriatic disease, and one of the benefits, if you will, of some of the small molecule therapies, including the JAK inhibitors, is that they hit several of those pathways, which in some cases is not a great idea in terms of toxicity, but in other cases, if there are more than one pathway at play in a disease, the biologics target very specific signaling pathways. And if there's more than one of those involved, maybe a small molecule that hits several is going to be advantageous. And interestingly, some of the very earliest data that we have for tofacitinib, which was the first JAK inhibitor to kind of hit the market in the US, was actually in skin psoriasis. And I'll show you some of that. So that's really the backstory of why we're thinking about these drugs in psoriatic disease, and particularly psoriatic arthritis. For us as a rheumatologist, a lot of interest in the dermatology community in JAK inhibitors, not just for psoriasis, but as you heard earlier, alopecia areata and many other skin diseases. And this is the paper from what at the time was CPP 690 550. It rolls right off your tongue. That's actually tofacitinib, and that was the name for it before it even had a generic name, let alone a brand name. All right, so on to the first question. And this is a patient that I'd seen, a 32-year-old woman. She's had psoriasis for a while and now presents with 6 months of pain, swelling in her hands. When you examine her, she's clearly got synovitis in several of her MCPs, her right wrist, and a number of PIP joints. X-rays are a little bit unclear. There's maybe a slight erosion at the third MCP, but it's not for sure. And you start to talk about treatment options, and the first thing she says to you is, needles are off the table. I'm not interested in needles. I'm afraid of needles. I can't even, give blood. It frightens me. She's got no other past medical history. She doesn't take any other medicine except for the topicals she's always taken for psoriasis, which just hadn't been severe enough to require systemic therapy. And she doesn't smoke, and this goes back to what Stanley talked about a little bit earlier. So what do you recommend to this lady? All right, it's shifting, but I think we've got the answer. And I think most people recognize that if she's telling you that injections are a non-starter, you might be able to talk her into an IV therapy. But if you're going to prescribe a subcutaneous thing that she does at home, and she's not going to do it, or being afraid every week to do it, then maybe that's a place for a JAK inhibitor, and we'll talk about what it means. So NSAIDs, I think the trigger in this one maybe erosion in her hands. And that's, I think, the thing that worried me. And she only had 6 months of pain. I do worry about somebody like this, even if I'm not 100% convinced. You could make the argument that an NSAID would be a great place to start, but make sure you follow up with x-rays in 6 months or another year to see if any of that is real, at which point she definitely needs some sort of disease-modifying therapy. All right, so now let me go back to her and say she's got a ton of psoriasis, a lot of psoriasis. And in fact, she's been on topicals for all these years, mostly because she had a dermatologist who was afraid to give her systemic therapy and really needed systemic therapy all along. She's now got about 10% body surface area covered with psoriasis, which is not trivial. Now what would you think about giving her? Okay. So this is kind of what I thought we'd get, and I think this is interesting because the bad psoriasis means you're willing to tell her, suck it up, you got to give yourself an injection once a month or every 2 months or every 3 months. And the advantage of the IL-23 inhibitors certainly is that they're much less frequent injections, so maybe that's an option. And I think people sort of back off a JAK inhibitor because of the perception, at least, and I think that it's not only perception, some of it's real, that they don't work as well for skin disease. And that's something I'm going to talk about. We're going to go through some of that. Okay, one last piece on this same lady. So she keeps coming back with more stuff. So now she says, all right, now in addition to everything we just talked about, she's got really bad axial disease. She's really stiff in the morning. And you talk to her and it's real. This is legit. Lumbar pain and stiffness. When she gets up in the morning, she has legit axial psoriatic arthritis. Now what? Okay. And again, not dissimilar to what I expected people would say. And I kind of agree with some of this. I mean, you may talk her into an injectable drug. I, too, would be a little bit less likely to prescribe an IL-23 inhibitor because I'm not persuaded, and this is a topic for a whole other talk and a whole other discussion, but I'm not entirely persuaded by the axial benefit of those diseases, those drugs, whereas an IL-17 or TNF inhibitor is certainly going to work. And we know that a JAK inhibitor works in axial disease. It's that many of them are now approved for axial spondyloarthritis. Okay, so let's move on to some data. Let's talk about this. So this is where it started. This was the pivotal trials for tofacitinib in psoriasis, just in skin psoriasis. And it's you can see that compared to the placebo, which is in a white box, sort of buried at the bottom, that are almost zero, it worked. There's absolutely no question about it. And this is looking at a PASI 75, and I can't remember what the difference of the two, but they're basically PASI 75. Oh, sorry, it's two different trials. PASI 75 result in both trials. And what was interesting in this was that numerically, at least, the higher dose, which was 10 milligrams BID at the time, 20 milligrams a day, before we had the extended release, was the clear benefit and a clear dose that worked the best. And when they took this drug to the FDA said no, because they didn't see enough benefit at the 5 milligram BID dose, the lower dose, and they were concerned about the safety data at the higher dose, okay? And Stanley talked about that a bit earlier, and the concerns about safety with all of the JAK inhibitors. There's very clearly a fairly narrow therapeutic window before you start to get into toxicity issues, which is why all of the drugs that we use in our space in the US were all approved at the lowest dose studied that gave a reasonable clinical response. So here's tofacitinib in psoriatic arthritis, and they did two pivotal trials there. Here's the DMARD inadequate responders, and what was nice about this trial is they threw in adalimumab as a comparison arm, not a control arm, because they didn't statistically compare it to adalimumab as an active control, but it was an active control just shown for a point of what does that do? And the answer was that tofacitinib worked pretty much as well as adalimumab for joint disease. And you can see on the left, the ACR response, and on the right, HAQ response, Health Assessment Questionnaire response, all better. And what you're seeing is the ACR 20, but the ACR 50s and 70s mirrored this. There was some skin response, similar to adalimumab, but it wasn't clearly statistically better than placebo. And especially when you look at TNF inadequate responders, the skin response at both doses was non-significantly better than placebo. And so I think this goes back to the early psoriasis studies, which say you can get somewhere with tofacitinib in skin disease, but you kind of really have to push the dose, and it's a dose that's not tenable right now in the U.S., given the landscape around these drugs, and knowing that we're using the 5 milligram twice a day, or now the 11 milligram extended release. Okay. Mentioned earlier, but filgotinib, boy, that's a pretty impressive ACR response there on the left. They were headed down the path for psoriatic arthritis before they pulled the drug, and I suspect, and I think I agree with Stanley, that a lot of it was this was going to be the fourth to market in this class. They looked at their data. The hook for filgotinib was that potentially it was going to have a better safety profile than the other JAK inhibitors. That wasn't 100% clear from the studies, maybe a little bit less zoster, but at the end of the day, I think they just made the business decision to say that the safety difference was not going to differentiate the drug enough, and it's challenging enough in a crowded therapeutic landscape, to come in with the fourth drug to market in a particular class without having a specific benefit. So it never went any further, but it worked. And then finally, upadacitinib. Okay, and this was the second drug approved for psoriatic arthritis from this class. And here's the data from the two pivotal trials of the upadacitinib. So here you have PsA1. These are people who are DMARD failures or NSAID failures, and they were randomized. They were all DMARDs failures. They were non-biologic DMARDs, and they were randomized to the two different doses of upadacitinib, because at this point it wasn't clear what the dose was going to be necessary. The 15 milligram daily dose had been approved for RA, not clear if a higher dose is going to be required in psoriatic arthritis. Adalimumab as an active control, but not the primary comparator. And again, drug was very similar. And here, actually, the PASI response is a little bit better and clearly distinguished from placebo. And so here you have a drug that, unlike in tofacitinib, where there was some skin benefit, here the benefit was statistically significant, both here in the bio-DMARD naive and here in the patients who had failed the biologic DMARD, mostly TNF inhibitors, but some IL-17 inhibitors. And again, no adalimumab comparator here, but you can see the skin response down there in the bottom left, which gives you some comfort that this is an option in patients who have active joint disease, but at least some skin disease. Okay. And then to go a little bit back into the backstory and the science, we all kind of know the pathway that JAK inhibitors work. We know that cytokines signal through a variety of cell surface receptors that drive what they're doing in their target cells. And for many of these cytokines, they signal through this JAK-STAT pathway, that the receptors on the cell surface is a JAK dimer, two different JAK kinases, sometimes the same, but often a heterodimer. Those undergo a conformational change. They stimulate STATs, which translocate that signal down to the nucleus and turn on or turn off whatever they're going to do and activate that cell. And what's become very clear is that this whole family of JAKs on the cell surface, number of different cytokines signal through different members of this family. As I mentioned, much of the time these are heterodimers, okay? And what shakes out when you look at this is the second one in from the left, and you see IL-23. So we've seen very clearly the IL-23, the benefit of IL-23 inhibition in psoriatic disease, approved now for psoriatic arthritis, but amongst the best biologics seen so far for skin disease. And it turns out that IL-23 is one of the few pro-inflammatory cytokines we've been busy targeting with biologics that actually signals through the JAK-STAT pathway in a way that we can demonstrate. And what it signals through is a heterodimer that includes JAK2 and TYK2. Well, that's not a JAK. It is. It's actually sort of the fourth JAK. And I have no idea why it ended up being called TYK instead of JAK4, but it's TYK2, and that's the fourth member of the JAK family. And if IL-23 signals to that, you can imagine that inhibition or blocking TYK2 might actually have some particularly useful benefit in psoriatic disease because we know that it blocks a cytokine that's really critical in psoriatic disease. And we've seen that as we've developed biologics. It's this whole Th17 pathway, and it's IL-23 that drives that pathway far upstream at the beginning of the pathway. And so you can imagine if you had an oral drug that blocked IL-23, that'd be pretty darn effective potentially in psoriatic disease. And lo and behold, it was. So now approved for psoriasis, for skin psoriasis. These are the two pivotal trials of deucravacitinib, the first available TYK2 inhibitor in the U.S. for plaque psoriasis. They did a really smart thing. They used as a comparator, the trial was powered against placebo, but they threw in apremilast as a comparator because they knew the audience they were speaking to. Dermatologists love apremilast. It's oral. It doesn't require laboratory monitoring, and it's pretty effective without significant inhibition or blockage of the immune pathways, immune system. And so the dermatologists love this because it's kind of a no-brainer for them, and it doesn't get them into the weeds that they had to worry about with some of the other biologics or with methotrexate that they never liked because of the monitoring that was required. And when you compare this to apremilast, you can see when you start looking at PASI 75 results, which is the result that the FDA uses to approve a drug, the drug was very effective. In phase 2, in psoriatic arthritis, also very effective. And you see here, ACR responses clinically significant at both the lower and the higher doses. And what's interesting about deucravacitinib is that maybe it's a little different than the other JAKs in terms of safety, because in the approval for psoriasis, if you look at the label approved by the FDA, it doesn't carry a lot of the baggage that the other JAK inhibitors carry, and it doesn't recommend any laboratory monitoring. Again, really nice for dermatologists, potentially for us. All right, so let's go to another case real quick. A 63-year-old guy, he's been following you for a long time. You treated him with etanercept. He switched after a couple years because his skin was okay. His skin was worse, and he did better with adalimumab than etanercept for skin. He comes to you and he says, I have to switch because my sister has MS. I've been reading the label, and I know that there's this link between TNF inhibitors and MS, and despite everything you tell him that that's your sister and that's not you, and I would continue the same drug, he's insistent. So what do you switch him to? Kind of what I expected, neck and neck. I mean, I think many of us would go with an IL-17 inhibitor because we know it's going to get good skin response. It should be equivalent to a TNF inhibitor for joints. But you also know that JAK inhibitors, and particularly upadacitinib, gives you the skin response that was equivalent to adalimumab in that trial. And so maybe that would be an alternative because he's done well with adalimumab. A word about toxicities. And we know all about some of this. The zosters, a big deal. And I'm not going to go through all this because Stanley took us through all this, but after the oral surveillance trial, all the issues about MACE events, malignancy, venous thrombotic events, we know about the laboratory abnormalities. I don't know if the TYK2 inhibitors are going to be different. So far, maybe. They certainly seem to have less issues in terms of lab abnormalities, whether some of this other stuff is going to be different. But I will say what we know to date is much like what Stanley showed you in RA, in that the risks are primarily in the people older and already at high risk for cardiovascular disease. Okay? And we know that in that population, there's a higher risk of these cardiovascular events with JAK inhibitors, or at least with tofacitinib, than with TNF inhibitors. And whether that's a unique risk of the JAK inhibitors or the TNF inhibitors actually reduce risk in that population, we don't yet know, but it's there. And the same thing holds true in psoriatic disease. So here again, another lady, 10 years psoriasis, she's been doing well on upadacitinib, and her joints are really well. And this is something we've been coming up with in the last year all the time. She comes to you and she's been reading the news, and she read how the FDA assessed the JAK inhibitors and said, they got to be after a TNF inhibitor, they're dangerous. She wants to stop taking the upadacitinib, or at least wants to know if she should. How do you counsel her? I think this one is as close to a right answer as any of the questions I've asked you, because I think it's very clear. She's very low risk. She's doing well on a drug. I think you try your best to reassure her and say, this is the data for a population of patients that I don't know that you belong in or fit in. I'm comfortable continuing this drug. I would tell her that, and hopefully she's willing to listen and remain and continue to be under control. All right, last minute or so, just a word about guidelines. So years ago, Ken Gordon and I came about with a way of sort of rethinking how you think about psoriatic disease. Because remember, in all these patients, you got joints, and in most cases, you've got at least some component of skin. The most recent iteration of the GRAPPA guidelines began to bring JAK inhibitors in. Now, they broke this up much, much more into all the different disease domains, but what they found very clearly was that for peripheral arthritis, for axial disease, the data on JAK inhibitors, if you don't think about safety as much, you just think about efficacy, strong recommendation in those populations of patients where those are the predominant disease manifestations. And even with enthesitis, with dactylitis, with skin disease, with the only exception being nail disease where the data isn't great, in all those diseases there's really good data to support JAK inhibitors, which leads to a strong recommendation. When they looked at people who had concomitant IBD, it was a conditional recommendation, but that's before the approvals. And now that these drugs are getting approved, it's often a really nice choice for those patients, especially because the gastroenterologists are willing to go with much higher doses. And so I can sort of get out of that argument and that discussion and let them drive the therapy. All right. So to wrap this up, why are we thinking about JAK inhibitors? I started with this question. Well, it works in both skin disease and joint disease. The joint efficacy in what we've seen to date is comparable to the effective biologics that we use frequently, TNF inhibitors and IL-17 inhibitors, and in fact now IL-23 inhibitors, though there's no direct comparison there either. The skin, the efficacy is probably less. It's comparable to adalimumab, which doesn't really stack up against some of the newer biologic pathways, but it works in multiple domains, including axial disease. Many people like oral drugs, so it gives us an option there. And the safety profile, I think, for the most part, has been reasonable until everything was sort of muddied up with the oral surveillance. But in the low-risk patients, I think it's still a very reasonable safety profile. And the last bullet is really a question we have yet to answer. Based so far, it looks like it's going to be different, but that may open up TYK2 inhibitors as a really nice pathway, because it does look like at least the toxicity profile may be different than the rest of the JAK inhibitors. All right, I'm going to turn that back over to Artie for your next talk, and I'll be back for the panel discussion. Thank you all.